Hi guys, welcome. How you doing? Loads of you guys joining already. Today we've got Kreena. I'm just going to invite her, and we've got a couple of really interesting cases to go through. So we'll get those up on screen for you. Oh, perfect. Keynote's just decided to start working, so we are good to go with the cases as well. Here's Kreena. Just seen her join. Let me add her on screen. Guys, down the bottom there's a little arrow. Just share this to a few of your friends who you think might be interested. Hi Karina, how are you?
Hi Dorilla, I'm good, thank you. How are you?
Good, thank you. Awesome. I was getting a little worried my keynote wasn't going to work. It was telling me I needed to update it, but I managed to get it up, so we're all good. This is looking. I've had a look at the cases; they look awesome. So I'm quite excited about this. How are you doing yourself? Are you okay?
Yeah, I'm good. I'm just like spending my time relaxing, not doing dentistry, which is feeling a bit crazy at the moment.
Yeah. Are
Yeah.
you having to go to guys at all?
No, because we're King's College London employees, so we're not. So the hospital NHS staff are working, but because
Okay.
we're clinical teachers, we're not having to go in at the moment.
So you've you've dodged the bullet maybe.
What about you? Are you doing emergencies at the moment?
Phone triage once a week.
Okay.
Um, I myself wouldn't mind doing some work, but we have to think about kind of I live with my grandma, so it's maybe not the best idea.
Yeah.
So I'd probably have to preclude myself on that basis. But we'll see. We'll see what happens. Hopefully things
Yeah.
are seem to be cooling down a little bit. We've peaked over here.
Yeah.
How's everyone in the comments doing? Say hi to Karina for us and invite a few of your friends. Karina, tell us a very, very quick version of your history and how you've ended up as a teacher at KCL on the endo program.
So, I mean, I graduated from Manchester, 2010, and then I moved on to my DF1. Then I did DF2, basically in peds and ortho. No, peds and ortho was like a 6-month post, and then oral surgery. Max Fax was the next 6 months. And then I sort of found that I really wanted to be good at one thing. And endo's always been something that, really interested me. I really enjoyed doing it in my DF1 year. And it was the one thing I felt that, would always hold my interest. I'd always be challenged by it. So I knew quite early on I wanted to do it. And then I did another year in general practice with a couple of part-time jobs in hospital. One of those I was doing endo using a microscope, so slightly more advanced endo. And then after that, I went and did my specialist training at King's College London, which I think is a fantastic institute to do your specialist training, especially in endo. It's got a great department, really excellent tutors. So when I finished that, I pretty much went straight into my teaching role. So I was doing a bit of undergraduate teaching initially. And then now I teach on the postgrad MClin Dent program. So yeah, it's really nice to give something back.
So how many years from, this is something we get asked quite a lot when we have relatively young clinicians who are, who've gone through specialist training. How many years was it from graduation to starting your program?
So 3 years. I started once I'd finished my third year, which I think is basically the shortest that you can do it. I think that's the minimum requirement. They ask for 3 years post qualification. But I was just really, it is quite a competitive program to get into. But I think I was just very lucky with the jobs that I managed to get, because I managed to get the endo post in hospital. And I think that's probably what swung it for me. And I was just very lucky, right place, right time for that to fall into my lap. And then I got it.
Yeah, because I'll be totally honest, it's probably the program I want to get accepted onto within the next 18 months. So that was
You're
the
the
leading
second
question.
person that's called me today about that then.
The leading question there, but yeah. Should we dive into these cases? Because we've got loads of guys who've joined us. Guys, we're going to jump into the case. I'm going to switch it round. I'm going to leave the comments on actually, because it's going to be on the top and Karina's going to be on the bottom half. But I want you to click the little arrow button down the bottom, guys, and invite some of your friends. So we're all getting this free education from Kreena, which is really, really generous of her. Okay, awesome. Should we dive in?
Perfect. So, do you want me to start talking about this one?
Yeah, sure.
Oh, yeah. So this is a patient that I saw. He came to me for a potential retreatment of that lower left 6. And the first thing, sort of, during our clinical exam, it was tendon percussion. He'd had sort of numerous flare-ups from it over the last few years. And then obviously when you look at the radiograph, you're seeing a huge radiolucency that's extending up into the furcation. In terms of pocketing, for endo, it's very important to feel around the tooth to see if there are any isolated pockets. So we can see that, that's showing that sort of a BP probe literally went down right to sort of the base of the tooth and the furcation. It's a very narrow, sort of isolated pocket. And that can tell us a few things. It can tell us that potentially there is a crack in the tooth because sometimes we get a narrow isolated pocket with a crack. Sometimes it can also tell us for lower molars, such as in this case, is that it's just a very large infection because the buccal cortex is so thick in these sorts of cases. Down at the bottom here, quite often the infection drains through the periodontal ligament because it goes through the easiest path of drainage, and that's up through the furcation. So it doesn't necessarily, I think sometimes dentists think it always means a crack, and for lower molars it definitely doesn't. It could just be a path of drainage, and we won't know if the tooth is cracked or not until we investigate it.
And in terms of your pre-op assessments, if we could just line them up almost one by one. So what's your first go-to, second, third, fourth, that, before you take maybe an x-ray? What's that step-by-step method that you kind of have?
So do you mean like history and then my examination?
Yeah, so you've taken the history, so the patients come, there's some pain from this, or I'm getting some funny taste maybe, or whatever it might be. Your clinical examination, so you've got the patient to open up the mouth. What's your stepwise kind of I don't know if you've got like a step-by-step thing you do.
So I'll always do like a soft tissue check before I start, and then I quite like to know, so is the tooth tended to percussion, because if you've got any sort of periopal area, normally, not all the time, but quite often that tooth will be tended to percussion. I'll check for tenderness to buccal palpation. Pocketing, I'll check usually with a Williams probe. So I won't normally use a BP probe because the end of it's quite thick, so we sometimes miss sort of narrow isolated pockets. So when you're checking, I normally walk the probe around the tooth very carefully. So it's not like how you do a BP, just check 3 points. It's literally walking the tooth, the probe around the tooth to see if it drops anywhere. I'll also check the adjacent teeth for any clinical signs or symptoms. And I will always do vitality testing. So I'll do cold testing to start with. And it's quite important that we use Endofrost. Quite a lot of people use ethyl chloride, and there's a massive temperature difference between the two. So ethyl chloride, you're quite likely to get false negatives because the temperature is about -5 degrees, whereas Endofrost is about -50. So always using something that's cold enough for us to get a response. And I want to make sure that the adjacent teeth are normal, because, quite often, especially with teeth that are cracked, patients can't identify which tooth it's coming from. Sometimes even the dentist that's referred them have got the wrong tooth because they've seen them when they're in a lot of pain. Sometimes, it's difficult to differentiate. So for me, I almost try to ignore the referral letter on the tooth type and, go and do my investigations on their own.
People do misdiagnose things, and kind of on the ethyl chloride thing, because I think it's an important point. In this case, we can see we've got a crown. So what are we doing when we've got full cuspal coverage? Do you kind of write it off, or what do you manage? How do you manage that situation?
I mean, what I'll do is, I mean, if it's the one that's tended to percussion, not tended to buccal palpation, then I won't bother with the sensibility test. If I'm a little bit hesitant, sometimes I will try the cold test, so I'll leave it on there for a little bit longer, because you can sometimes get a bit of diffusion of the cold within the tooth, but you're much more likely to get a false negative, and that's something that we just have to accept. If there is a little bit of tooth on show, so for example, if it's a 3/4 crown or something like that, I'll usually test the bit that's not covered, and I find EPT really useful as well. I often find that sometimes with cold we don't get a response, but with EPT, it's quite painful for the patient. So it's, we tend to get a response from that. So if I get a negative, I'm expecting a positive, I will always double check it with EPT.
Okay, awesome.
Yeah.
Any
I also
questions
really like
down
the
below?
tooth sleuth for cracked teeth.
Yeah.
Which is basically testing the cusps individually. So each sort of cusp gets tested. I get them to bite down, jiggle the end of the tooth sleuth, and see if that that causes any response.
Yeah, perfect. I think we answered that question already from 5AIM, so that's perfect. So yeah, you've made your kind of clinical testing now. Now we've taken this radiograph. Should we focus in on that now? We already know we've got a pocket on the buccal side. So we can see there's obviously a large interfurcational radiolucency incorporating your both apices, mesial and distal. And that kind of marries up with what we've seen there. We've also seen that we've got some sort of a root canal being tried before. What indications does this give you about what you're going to see when you get in there already?
So I think the first thing that I look at is that there looks like there's some distal caries or some sort of distal leakage underneath the crown there. So, the first step I would always do, especially when I see a radiolucency like that, is take the crown off to have a little look. So I'll talk to the patient about prognosis, and if the first thing I'll say to them is we take the crown off. That doesn't apply for if there's definitely caries. For that one, it's quite obvious problems underneath that crown. But for all crowns, I tend to take them off. For all restorations, I'll strip the tooth. There's quite good evidence for doing that. So studies have shown that nearly 100%, I think it was 99.6% of teeth, if you remove their restoration, there'll be some degree of micro leakage underneath that restoration. For endodontics, we know how important the coronal seal is. It's been shown by multiple systematic reviews that the coronal seal has got a massive impact on the success of root canal treatment. So the first thing I'd be telling the patient is we take the crown off, we see if there is enough tooth left to save. If there is, then we proceed, and if there's not, obviously then it's back to your dentist to have the tooth taken out. But it's very important, I think, to always strip the restorations out, because I think you'd be surprised. For me, 99% of the time I'm glad that I've done that. So that's the first thing. The second thing is we can see that the dentist has struggled to do the root canal treatment. And one of the main reasons is because we can see that the pulp roof hasn't been removed. So we can see that tiny bit. That's the pulp chamber there. And what's happened is when they've attempted to do the root canal treatment, they found the pulp horns, and they've therefore thought that those were the canals, and done the root treatment through that. And the negative of doing that is they haven't managed to get straight line access, and obviously therefore struggled to get down the canals. And when I look at that from a retreatment point of view, what worries me is that the mesial root looks like it's quite straight. Can you see the GP looks quite straight, almost like it's not in the right line of where the canal is meant to be. So I'd be suspecting that there is a ledge in that root right from the offset. And it's much easier to create a ledge if you don't have straight line access, because that your files want to go in a straight path, and so it's quite easy. So initially, just looking at that radiograph, I worry about the prognosis of it. Firstly, because of the size of the lesion, we know that bigger lesions are less likely to heal. We know that this is a perio-endo case because there's a deep isolated pocket, so there potentially is a crack in the tooth, or a very large infection that's draining through the furcation, but that immediately lowers the success rate. And also, I would be telling the patient, okay, there possibly is a ledge in this mesial root. We might be able to bypass that. We might not. Some severe ledges, especially if the canal is actually calcified beyond that.
And we don't see a very obvious canal underneath there. So
so those are the types of the conversation I'd have with the patient, and then see where they want to go from there, really.
So let's just say we've had that conversation. We've given them the pros and the cons. Are you removing the crown yourself? So this is one of the questions we've had. You do that yourself?
I tend to do that myself. If the referring dentist wants to do it, that would be fine for me. But I always like to strip the tooth completely before I do root canal treatment. And it's a little bit different to, I think, how some people do it. Although I think endodontics is moving towards this way, which I think is a really positive thing. I think that, we need to assess these teeth to see if they're restorable first. We need to make sure there's no coronal leakage. The post-operative seal is going to be good. So I quite like to, I'll strip the tooth myself. Any restoration that's in there, that includes an amalgam or any composite, even if the restoration looks sound, because if it is leaking, it will significantly impact that, the long-term prognosis of that tooth. So I literally strip everything from to tooth. Then I will build that tooth up so that there is a four-walled access cavity. Okay. I don't know if the next slide shows that. I think it's a different tooth, but basically I'm just showing that that's obviously obturation, but that's the state I have it when I'm doing root canal treatment. So I completely strip it. I'll then put a matrix band on and rebuild that distal wall up so that there is a four-walled access. And again, loads of benefits of doing that. The first is that, we know that we can get a good seal with a matrix band, which is really important.
We've got a clean area as well then.
Exactly, yeah. There's no caries, so no bacteria that's going to go there. We get a really good seal with our rubber dam. So, half the time you're worried if the hypochlorite is going to leak out into their mouth or saliva is getting in through this sort of open distal, distal area that we've got. So this way we've sort of, it's something that's significantly changed since I did my specialist training. When I was doing general dentistry, I never used to do that because it takes a long time in the outset before you even start the root canal to do that. But I think, having done it now, it makes life so much easier. You literally have a beautiful rubber dam seal. You have an irrigant pool in the pulp chamber. And so all your files are then passing through hypochlorite. You're not worried about any leakage. It's a really good way of doing things.
Yeah. And just rewinding on to just before we start, for example, we had this conversation with Brett from the States, Brett Gilbert. He says he takes more or less a CBCT before every case, or more or less every case, not always, but more or less in that sort of way. Obviously, we're a little different in the UK. Where do you land on that spectrum? And what is your criteria for using a cone beam, if at all?
So obviously my training was done at King's, and we take a lot of CBCTs. We're sort of the institute, at Guy's, that a lot of the research is done there. We've got Shannon Patel and Professor Minocci, and both of them are sort of leaders in cone beam CT. So we take a lot at Guy's. In practice, I don't take as many, I have to say. I quite like to take it for retreatment cases.
Is that because of resorption? Is that because of access of the machine, or because you're not saying it's clinically necessary in those cases?
Yeah, we have a cone beam on site now. We got one, I think, about 6 months ago or something like that. So it's not due to lack of access. I just feel that if I don't really need it, then I don't want to expose the patient. I just don't want to.
Straight premolar, why do you need it?
Exactly, yeah. If I feel like it's going to change my management, or for example, if I start treatment and I see something that, okay, this is a little bit unusual, then I'll tend to take it.
I think you hit the nail on the head there. If you don't think it's going to change your management, you shouldn't be taking it. I think that's probably going to answer the questions about cone beam that we had in those questions down there. So I think that's probably the most concise way of saying it.
Yeah,
so that's good.
Yeah, there are some cases that I definitely take it. I know we're going to talk about a resorption case maybe later, so anything that's got resorption, I will definitely take a cone beam CT. Any surgical cases, any cases where I think the anatomy is a little bit unusual, so these sorts of things I definitely take. Sometimes complex trauma cases, I'll take a cone beam. So there are definitely cases where it's 100% I'll be taking it, but on a general basis, it's not that every patient that walks through my door has a cone beam.
Yeah, for sure. And we had another question. It's talking about the roof. Yeah, we did speak about the roof, saying that's possibly one of the reasons why we had a ledge. So we did notice that. Do you put a temporary crown afterwards in the intermediary period?
Yeah. So I'll always leave them with if I've taken a crown off, then I will always leave them with a temporary crown, and then give the index back to the referral dentist, so that that it's easy for them to then re-prep the tooth and have a new temporary.
And the distal wall, was that composite? Yeah,
I'm a big composite user. So yeah, for me, 19 5% of my work, it will be composite that I'll rebuild. And I just feel that if you know, for teeth that need endodontics, we are working with quite broken down teeth. And in that case, you know, quite often you strip out an amalgam and you're seeing crack lines instantly. Or our teeth that, you know, the teeth that we work on are quite heavily broken down. I just think composite bonds to the tooth. So, you know, I'm very much a fan of adhesive dentistry.
Yeah. And we'll move on in a second. Iman, yeah, I would turn the comments on if off if the slides are on the bottom half of the screen, but I think people find it easier to use the comment than the question box for some reason. So I'm leaving on this one because obviously I'm just going to move my head out of the way and have this bits on the screen. So in terms of what you did once you got in there, I think this is quite key. So can you share the tips on navigating those calcified canals or difficult areas in that tooth?
Yeah, so the first thing obviously that I would do is remove the GP that's, well, gain full access to the pulp chamber. So I tend to use an Endo Z burr for this. So Endo Z burr is basically a non-end cutting burr, so it only cuts on the walls. So what happens is, as you put it into where they've dropped into the pulp chamber, you can literally just move it sideways and very safely remove the roof of the pulp chamber without, you know, risk of damaging the floor of the tooth. So that's the first thing I'd do. And as soon as we get into that pulp chamber, it's going to be very infected, and the majority of bacteria are coronal. So, you know, it's instantly using hypochlorite, getting rid of the majority of debris that I can with hypochlorite, rather than going straight in with my files and trying to remove anything. So a lot of coronal disinfection. And then for a case like this, I'm not looking at removing the GP with solvent if I can, because you can see it's quite poorly condensed GP. So it's unlikely that I'm going to need a solvent to remove it. And if I don't have to use a solvent, I don't, because it gets quite messy with a solvent. You end up with sort of a smear of GP on the walls of the canal, which is then a bit more difficult to get out, blocks the tubule. So if I can avoid the use of a solvent, I do try to. And in a case like this, you can. The GP I would tend to remove with either hand files, so normal K-flexo files, or Hedgestrom files. If it's a little bit more densely packed, I'll tend to use rotary files. So I really like Reciproc to remove GP. It removes it really well. The only problem I have with using rotary files to remove the whole of the GP is if you've got a ledge, it will likely make that ledge worse because it's you know, going in at a straight angle. I think Reciproc's a real culprit of that. So although I do use it, I always, particularly in that mesial root where I'm worried that there is a ledge already, I'm gonna definitely not take my Reciproc all the way to the base there. The last bit is always going to be removed with hand files. So majority gets removed with rotary files or gate Sliddens at the very coronal bit. And then I'm sort of taking a pre-curved hand file down there to try and sort of scout out the ledge. In this case, there was a ledge.
C+? Sorry, are you a proponent of C+ files?
Yeah, so I won't tend to pick up C+ as my first file. It will always be normal hand files first. The reason I don't like C files initially is because you are more likely to ledge with them because they're a much stiffer file, and they're a little bit more pointy at the end. So if I've suspected that there is a ledge or something like this, I'll try initially without C files. If I'm not getting anywhere, then I will then start to pick up my C file, and I'll always put like a little curve on the end of the C file to, you know, to not try not to ledge with it basically. But for calcified cases, C files are fantastic. Again, with this case, because I'm suspecting there's a ledge, even though the rest of the, you know, the tooth is calcified or appears calcified, I don't like to pick up EDTA too early because it's the same thing. EDTA is a chelating agent, so it dissolves inorganic debris. So if we take EDTA in too quickly in this case, and there is a ledge, our hand files could potentially, you know, the EDTA would soften that area, and our hand files would make that ledge worse. So I'm only picking up the EDTA once I realise I'm in the true canal. So it normally, a real canal, if it's calcified, it will feel a little bit sticky with the hand files. So, you know, sometimes you put your hand file in and it reaches like a dead stop, like it's like a
hard, just like
hard,
yeah.
So So in, you know, for that, I'm a little bit like, you're a bit worried, am I in the canal or am I in the ledge, is when I'm feeling that. But if I then, you know, if you pre-curve your hand file and you're feeling stickiness, it's like a little, you know, you get a little tug back almost that you get when you're putting your file down. That's
It's almost it's almost like you when you're testing your GP and you've got a bit of a little bit of, not quite the same because it's got a weird. You're right. It's almost like you're pushing through treacle or something. A very very thick, squishy sort of weird feeling. It's hard to describe. You're right.
Yeah. Sticky, I think, is a
yeah.
good word. Yeah. So when you feel the stickiness, that's when I then think, okay, I'm in a calcified canal here now. And then I'll usually use a little bit of EDTA and then C files just to be able to negotiate down.
Awesome. We've got a question. Would you use the braiding technique with the hand files in this sort of case?
No, I don't think so. No, because it will come out fairly straightforward in this case. Braiding, I normally use if there is an overfilled GP point. So say you know, the distal canal, say that had a GP point beyond the apex. I then don't want to physically remove the whole, you know, the GP point in terms of, you know, sort of digging down it, because I'll then not be able to remove the extruded part. So that's the times that I tend to try using a braiding technique. Or if there's a fractured instrument and I can feel around it, and you know, then I'll try and sort of use a couple of files to braid that out. But for this, I'm not worried about extruding that GP at all, so there's no need for me to have to braid it out.
Sure. And you used reciproc in this case, not true anatomy, is that right?
So I think this was ProTaper Next, actually. So the only reason I mentioned reciproc is because I use that in a lot of my retreatment cases. But for this one, you know, the GP is not that well condensed, so normally my file choice is ProTaper Next. I just prefer, I think the tape is a little bit smaller on ProTaper Next, and I prefer the tactile sensation, the feedback I get, especially in calcified canals, because I feel like with the reciprocating system, you lose that tactile feedback, which I like to have.
Because it's got both movements, so it's harder to tell where you are.
That's it, because it's going backwards and forwards. So it's a little bit, you lose a little bit of that tactile sensation that you get from a rotary system. But that's complete preference. You know, it's a clinician's preference. Some people are used to using reciprocating files, and that would have suited them. But I really like ProTaper Next, as it's sort of my main system.
Yeah. What's interesting in this case, sorry, I'm just about to hiccup. We can see in kind of the apical third, we have got some bit of a curve on both of these canals. What's your sequence for getting around these curves without, again, ledging or stripping or widening the canal in a way that you don't want to?
So the main thing is, if I worry that there is a curve, what I'll normally do is, as soon as I can get in, so after I move the GP here, I would have normally gone in with a size 10 file, pre-curved. So make sure, never take a file in straight, always pre-curve it. And then I'll normally feel how far that will go down. So if that's going all the way to the apex, and I'm getting an apex locator reading, I'm not too worried about curvatures. And then my next file is, you know, straight onto a rotary. If I feel like it's a bit tight, so for example, when you hit curves and things like that, quite often your file will start to bind a little bit. And at that point, you start to lose tactile sensation from your hand file. So what I'll then do is I'll use my rotary system up to the level where that file is binding. So for example, if the file is getting quite tight at about, you know, 18 millimeters, what I'll do is up to about 17 millimeters, I'll coronally flare with my rotary system. So if it's ProTaper Next, it'll be X1, X2. And then I'll take my hand file back down again, pre-curve it, and then take that back in. And the benefit of doing that is actually now you're feeling, you've got much better tactile sensation of the tip of that file rather than the whole of it binding. So you're less likely to ledge. You've also created a little bit of space, and quite often with tight curves, as long as you've prepped, more coronal to that, you get that better tactile sensation will make you be able to get to length.
Yeah, also, I think that kind of answers the question, because there are some clinicians who have almost a sequence of, they do the initial third with an opener file, which is a rotary. It might be whichever system you're using. Then you.
So I definitely do that. Yeah. So I'll always use an XA, which is part of the ProTaper Next sequence. It's like a stubby 18 millimeter file.
Yeah, it's really short.
Flare. Yeah, and then it will be the size 10, sorry, and then basically what I said. So if I can get to length, then I'm just going to length. If I can't, I will never put too much pressure on my hand file, because that's when you either break them or you ledge. So then it's sort of prepping the coronal 2/3 or literally a millimetre from where I can get to, and then I'm going the full length.
Yeah. In terms of saying you're losing that tactile sensation, is that when you start to feel the handpiece judder? Is that what you mean? If when you're very, very nicely,
I mean with my hand files, actually. So, you know,
okay.
Yeah, you know, so with my hand files, if what I mean by losing tactile sensation is that that I feel like the whole file is binding. I'm not sure where it's going. It's very tight everywhere.
Okay.
So that's what I mean for that. But when I mean tactile sensation for rotaries, yeah, it's more, so say your torque setting is 2 or 2.5, you start to notice it's starting to, you know, your handpiece is starting to make a noise. It's approaching the torque. Yeah. That sort of the manufacturer told you to use. So that's what I mean by that. Whereas with Reciproc or Wave 1 Gold, sometimes you lose that tactile sensation completely, you know, because the first thing that you get is that the handpiece auto reverses.
Because it will just cut until it decides it doesn't want to cut and sends you back out. Got a question from Torkan. He's asking about RC prep. Can we use it as EDTA? As far as I'm aware, there is EDTA within that solution.
There is, yeah. So it has about 17%. All sort of lubricants like Glide, RC Prep, they all have a little bit of EDTA in them. It's about 17%. So yeah, I mean, the ideal is that you use those lubricants with hand files and not with rotary files, because it reduces the cutting sensation, the cutting efficiency of rotary files. I have to say, I use them with rotary files too. So I think I'm a little bit of an anomaly in that, but I like using lubricant with my rotary files as well. There is evidence that EDTA as a penultimate wash, so that's EDTA solution, if you use it for 1 minute as a penultimate wash, so that means you use it and then you use hypochlorite after that. If you use it for 1 minute, then it will increase the success for root canal retreatments. So
and on that, do you see the question at the bottom? Do you use saline in between the hypochlorite and EDTA?
No, there's no severe interaction between the two. It's only if you're using sodium hypochlorite and chlorhexidine that you do need to then rinse between, usually with alcohol, because it forms a precipitate called parachloraniline. And that it blocks dentinal tubules. It's like a brown precipitate, and it's also potentially carcinogenic. So between those, you need to flush, but between hypochlorite and EDTA, you don't need to.
Awesome. Any last questions on that section of the treatment? I think we've covered that really, really nicely and quite in totality almost there. So when you're now obviously at the point of now wanting to fill this tooth, are you using a backfill technique? Are you using a straight master cone and then accessories? Where do you lie on that spectrum?
So I tend to always use warm vertical condensation, which means that we put our master point in, we then take a heated plugger as far as we can go, if we can, to 5 millimeters from the apex. Obviously in curved canals you won't be able to do that. In very small canals you won't be able to do that. But as far as we can go, then you condense that apical bit with a plugger, like a Mach 2 plugger, and then you backfill the rest of that space with warm GP. So I quite like using that technique. I think we get a really good 3-dimensional filling of the space. And we know that, you know, if there's a lot of space left around GP, the sealer is the weakest part of root canal filling. And if bacteria can sort of travel up and down where your GP point is, then potentially, you know, it can reinfect the apex. So the better the filling that we get, we entomb the bacteria, any bacteria that's left. So yeah, that's what I tend to use.
Awesome. Is that system B you're using, or is it a different one?
System B, so I use the Element system by Kerr, which I think is a very clean system. I've had mine for about 7-8 years now, I think, and it's never gone wrong, so I really like it. It's not the there's two of them, but I prefer the corded version. The cordless version tends to lose battery. So if you're doing a lot of endo, it's not the best one to have because you'll have to charge it, and you obviously don't want to have
And the
to charge
batteries
it.
actually die. You need to replace them, which is really annoying.
Oh, okay. Have you had experience too?
The one that I have, it's not a system B or anything like that. I'm talking more of the actual endo handpieces.
Oh, right. Okay. Yeah.
Cordless handpieces, whichever type you have, that lithium-ion battery eventually just comes to a point, like in a phone, where you've used it too much and you just need to get a new battery.
Yeah.
Having a cord, as annoying as it is sometimes,
Yeah.
saves you shelling out, or the practice shelling out for that particular bit of kit, or all the time.
Even my endo handpiece is corded, like what you're
Mm,
saying. It's I find them lighter as well. They're not as heavy.
yeah, because the battery's not on the bottom end of it. Yeah.
Yeah.
Do you soak canals in any hypochlorite for any length of time?
I do have an irrigation, so like regime. So I
Yeah.
tend to warm my hypochlorite, which I do really cheaply in a baby bottle warmer. So you can't heat all your hypochlorite. You have to take out what you need, because as soon as you start heating it, the efficacy of it goes up and then it goes down again. So don't heat all of it, just heat what you need for that patient. So I normally have water in my baby bottle heater. I'll have another little bottle in there, which my nurse has poured the hypochlorite that I'm going to use in there. So I warm it. I then, after I fully prep the canals, I'll spend a good 10 minutes, 10, 15 minutes just cleaning the canals with the hypochlorite, even though I've used it throughout treatment. So I use so much hypochlorite that it's annoying for the nurse. So hypochlorite's the main thing that's disinfecting your root canals. So I tend to have 2 syringes on the go, actually. That's how much I use. So when I'm done with one, I've got an automatic one coming and she refills the other one. So lots of hypochlorite. I tend to, once I've fully prepared my canals, I'll put hypochlorite in them, and then I'll agitate it with I've forgotten its name, Endoactivator.
Awesome.
So
You got one of those. Yeah.
Yeah. So the endoactivator, I prefer it to ultrasonic activation of my irrigant, because it's a plastic tip. So when you're using ultrasonics to activate your irrigant, if you're using it in curved canals, firstly, there's a potential the ultrasonic tip that you're using can break. And the second is that if it's very curved, it can start preparing the canal.
You can
so you don't worry
because it's
about
metal.
that. Yeah, so you don't worry about that when you're using a plastic tip. So I tend to use the endoactivator. And you notice the difference, actually, when you're using it, you see the solution become cloudy the first time you use it. Because root canals aren't just round, we've got isthmuses and lateral canals and deltas. So I think the more we can agitate it within the canal, the better the disinfection will be. So about 10 to 15 minutes after I've fully prepped, but I've used a lot of hypochlorite through treatment as well. And then I dry and start to fill.
Awesome. Have you ever had the chance of using the VDW Eddy?
No, I haven't.
I'm dying to get my hands on it.
Well, let me know how you find it. No, I haven't tried it, actually.
Awesome. Last couple of questions. Oh, there's loads of questions here. C files. That's when do you use the C file? Just very quickly.
Yeah, so C files is if I'm struggling to get down the canal with a normal like a flexo file.
Yeah.
So for me to pick it up, I'll have to know I'm in the canal. So I'll be experiencing that slight sticky sensation with my normal file, so I know I'm in the right place. Because it's very easy to ledge or to even perforate with C files. So I'll make sure I'm in the canal, and then I pick up C files. Normally for calcified cases. If there is a ledge, sometimes I use them as well, and put tight kink on the end of the file, and then just scout the walls of it.
Yeah.
Sometimes it's a little bit stiffer, so you drop in. Yeah.
Awesome. That's that question. Best way to avoid voids. That's using the heated system that we talked about, system B. What's your sealer of preference, and does the local anatomy influence it?
No, I'm very boring when it comes to sealer. I use a zinc oxide eugenol based sealer. So I use Pulp Canal Sealer by Kerr. I like it because you mix it to the consistency you want it. So if I'm treating a tooth with a slightly wider apex, then I might mix it a little bit more thicker, or if I'm close to the ID nerve or close to a sinus or something like that. So my nurse will mix it a bit thicker. I like that you can control that aspect of it. I find that it's quite radio opaque.
Yeah.
And when we fill with heat, we sometimes get sealer puffs. And I find that if I get a sealer, I don't aim for them, but if I get a sealer puff, then I'm not worried about sending it back to my referral dentist, because I know within 6 to 12 months that sealer puff is going to resorb. Whereas with some sealers, for example, AH+, which is a resin-based sealer, if you get a sealer puff with that, it takes a very long time, if ever, that is going to resorb.
And there is some suggestion that having a tiny bit of seal through the apex will agitate your your osteoblasts and osteoclasts to bony infill. I don't know how well supported by evidence that is, but there's some people saying
not very well. The last sort of clinical study that came out showed there's no benefit or negative to having a sealer puff. I mean, in America we aim for them, and when I was doing my postgrad training, I would want to get a sealer puff, you know. But it's turned into a U-turn opposite in practice, because I think I just think that if we don't have to put something beyond, then I don't like to. I don't mind if I get a sealer puff, but I'm definitely not aiming for one.
It's just a side effect of a well cleaned canal. You may get it, you may not, but you're not trying to open it up so much that you get some.
That's it.
How about in severely curved canals, where what heater point can reach that apical 6 millimeters if it's severely curved? I think we're talking about the heated system there.
If it's severely curved, you're not going to get anything to about 6 millimeters, and you don't really want to push it to that level anyway, if it's very curved, because you're obviously pushing a metal object around a curve and it's just not going to go. You're just going to put pressure on it. The only way to sort of, I mean, even with cold lateral, you're not going to get a spreader to that level anyway. The only system that would get a heated sort of point to that level would be something like thermofill, which is a carrier-based technique. I don't like thermofill at all, or gutter core, or any of that. I just think you have very little control over where you're pushing your GP. Quite often your carrier might get to length, your GP doesn't get to length. I hate retreating them. So I don't like carrier-based techniques, so I don't tend to use them. But I just think at that point you're relying a little bit more on your sealer. You get down as far as you can. You can use a slightly more tapered heated plugger as well.
So I've got Mash 2, which is pretty small, but you can get smaller ones as still, I believe. We've got so many questions, guys. Thank you very much for this. In terms of removing the GP, please watch it back afterwards. We did go through that in detail, so it will be up on Story. And I think because of the number of questions that we've answered, I'll actually download the file and look to posting it at some point, if that's okay with you.
Yeah, that's fine.
It will be played back again. So to answer that question, bleach. In terms of bleach, what percentage are you using in the NaOCL?
I use about 3.5%, depending on what practice I'm at. I don't like to go as high as 5-6% because I heat it. Heating is almost a safer version of going to a higher concentration, because you get more efficacy out of it.
I always describe heating it as, do you remember when we used to do little chemistry experiments? When you heated a substance, you could see it moving around much faster. So you needed less of it to get to all the sides, if that makes sense. So that's why we do that.
The other thing is with higher concentrations of hypochlorite, you damage dentine a little bit more. So there is, with any hypochlorite, you are damaging your dentine, so you're reducing the micro hardness of your dentine. But taking it all the way to 6%, for me, I just feel like 3.5 is enough. As long as we've replenishing it frequently and heating it and things like that.
Haas is asking, Bid Tooth Fairy is asking, would you guys recommend a bioceramic over a tubular seal?
Not currently for me. There is loads of endodontists using it, and as a sealer, it is in theory meant to be better. The last conference I went to, which was ESC, the European Society of Endo conference, the problem some of the speakers were saying was that actually some of the bioceramic sealers aren't setting. So firstly, they're very expensive, which is fine. I think you want to use the best material in your patient if you're charging for it. But for me, I worry about that if they're not setting, because that's a massive issue if they don't.
It's a whole thing.
They don't set. I don't like single point fillings if I can avoid them. And with bioceramic sealers, you can't use heat for the majority of them because it causes problems within the material. So you should be using it as a single point without heat. And if I use System B, then I can't use a bioceramic sealer. So that's another reason.
Everything else you do.
Yeah, and there's not enough evidence about it. I do worry about also retreating those cases. So you can remove the GP that's around the sealer without a problem. But if you can imagine the case that we talked about, if there was a ledge in that tooth and the dentist had used a bioceramic sealer, there's no way I'm getting down that canal because it would completely block the true canal because there'd be no GP there. So I think retreating them is going to cause a real problem in the future. So yeah, that's a couple of reasons why I'm not for them at the moment. But if things change, if evidence changes, maybe we'll change.
Yeah, for sure. Somebody's asking about marginal elevation. We might cover that in a future session because that's a whole conversation on its own.
I've just seen Ahmed, which is like Abs Endo. He is doing a live talk right now, and he's on. So nice to see you, Ahmed.
I want to get him on. I've seen his page so many times. I'm like, I'm gonna press message, but he's just gonna ignore. I just hope he's gonna.
He won't. He's lovely.
Yeah, I fanboy a little bit with the endo guys, to be honest. So I'll say that.
No, we're a friendly group.
Right, so I think we've pretty much got to the end of that case. Would you say?
Yeah, I think we've covered it.
Let's just see. Have we got anything on the tab down the bottom? Is gutter core obturation better than System B? I think that's a personal preference.
He wants a reference for it.
Yeah. Somebody's popped that in the questions there. That was Nico.
God, I don't have a reference for it.
A preference, personal preference.
I don't like gutter core at all. It's I hate it. I hate retreating it. It's very hard. It's very difficult material to control. You're heating this like hot thing, you're sticking it down. You don't know if there's GP coming out the end. You don't know if it's sealer coming out the end. I personally don't like it. I don't think it's a predictable way of filling root canals.
Yeah. So I think we've kind of got to the end of that one. Has anyone got any more questions with regards to that case? I'll just show you the slides again because it was a bit of a banger. So there we have the pre-op, unroofed, possible ledge, very spindly sort of GP, and then Kreena's gone ahead and retreated, and now we've got this. We can already see some bony infill. What recall was this?
So that was 6 months. So I normally, the guidelines say we review at 1 year, which is normally what I would have done here. The problem is the patient came back to me at 6 months and said, I'm having a slight ache on the left-hand side. So I wanted to see, because I was worried maybe, it's one of those, massive lesions. It might be a cyst. It might not have worked. So I reviewed it a little bit earlier. So this was a 6 month recall from what I remember. And it was healing fine. I think he was probably getting TMD on that side. Yeah.
And in terms of the post-op, the core and then the crown over the top, is that something that you do yourself or you leave for the referring dentist?
So I always put my own core in, whether that's a post, a fibre post, or a composite core. I like to do that because whenever I see a patient, if it's a molar or premolar, you're getting a cuspal coverage restoration with your dentist afterwards. And the amount of, sometimes I'll even leave an open contact. For me, it's almost like I try and leave an open contact because then it bothers them so much that they go back to their dentist for the cuspal coverage. But there's so many patients that don't, that they, it's not hurting anymore. They forget, or, they lag it. And the problem with leaving a temporary for me is that, one, the tooth is in a weak position because it's got a temporary, and endodontically treated teeth are much more likely to fracture. So that's the one problem. And the second is if that temporary comes out, it's leaking straight back into my GP.
And you've got to redo it, which is great.
Yeah, such a pain. I really like, I prefer, I'm putting a composite core in. I'm usually putting that composite core quite far down the canals. I know it's well sealed. I'm happy with it. And, I'm doing that all under rubber dam. The patient, in terms of the patient, they've only had to have rubber dam on once because majority of my treatments are one visit. So that patient is then left, that core is sealed, the GP is sealed, everything is nicely placed. And I think that dentist is now in a perfect position to get that patient in for a cuspal coverage restoration. I just don't see the point of the dentist having to you know, put a rubber dam on, which, you know, are they going to do? Are they not going to do?
Can they do?
Yeah, I mean, totally understandable why they don't, you know, because you have to numb the patient up to do that almost, because to get the clamp on the tooth and all that sort of thing. And for the patient, it's not very nice because they're having to have that done before the custable coverage is done. So I think you just have to work with the right people. And I'm very fortunate that the dentists I work with, you know, I work this way and they work with me that way. And it's just very nice to do that. I think I wouldn't sleep well at night if I hadn't done that. So for me,
do you work in the same practice as the referring dentist normally, or is it?
So the majority of my referrals are external.
Okay.
So yeah, majority. I do work, the practice that I do work at, we do have general dentists in them as well. So I will see some of their patients as well. But majority is external referral for me.
Yeah, because I'm going to tell you the story I tell
spot.
everyone. There's one practice I know of where, as a specialist endodontist, he employs himself a general dentist who will bring the patient in and access, remove all the caries or whatever you want to do. Once he's accessed, he sorts it in and then sits down and does the endo. That guy then comes back afterwards, places the post, the core, preps it, imps, and then the patient's back the next week for the crown.
Oh wow, okay, yeah. Yeah, I mean, for me, it's like, if I was having my tooth done, I'd want it done one visit if I can, like, you know, worst 2 visits, and then be done with the LA and the dam and everything, and back to their dentist. So yeah, I mean, I don't place any crowns or anything like that. So I think it is important for the, you know, the patient's general dentist to know how much tooth is left. So if there isn't very much left, what I tend to do is, before I build it back up, I'll take a photo, so they know a little bit better on, you know, how they're going to restore it afterwards. You know, whether this tooth needs an onlay, or you know, I need to go a little bit further here. So yeah, I've got Harj. I can see Harj's comment down there. I work with Harj, so yeah, it's you know, I think it is important to have that relationship with the people that you work with. But I mean, yeah, I think in different countries it works differently. Sorry, it's my battery. I know in America it tends to, you know,